Hello, everyone. Thank you very much for joining. We are going sort of back to basics with this session, and we're going to be talking about ocular surface disease, specifically talking about dryness. I have had a previous session looking at epiphora, and some of the topics do sort of overlap slightly, but specifically, we are talking today about dry eye disease. So going back to the tear film, we have discussed this before, but there are three layers, and it's a very, very sort of complex composition of immunoglobulins, proteins, and actually some research has shown that there are thousands of different types of proteins and immunoglobulins and amino acids and compounds in a tear film. So you can imagine trying to recreate this with drops is incredibly difficult. So there are three main layers, as you will know. You've got your lipid layer by your meibomian glands. This is your sort of fatty layer. It's a surfactant and it essentially reduces the evaporation of the tear film underneath it. Your aqueous layer from your lacrimal gland. This has both a basic and a reflex component. So you've got basic secretion, and then depending on whether or not there's like sort of surface irritation, you'll have a reflex component as well, which is why sometimes you'll be left with a watery eye if there's an ocular surface issue, because actually the reflex component is an overdrive, and that aqueous layer is essentially what's transporting oxygen to the ocular surface. And then finally, the deepest layer is your mucin layer. That's released by the goblet cells of the conjunctiva, and that essentially acts as both a lubricant, but it also just permits the wetting of the surface of the eye, by allowing that tear film to actually attach on. So all three of these layers are equally important. And a problem in any of them can actually then present with dryness. So your dry eye disease can either be instability of the tear film due to whatever problem. That's usually due to a problem of the your meibomian glands. You've got tear hyperosmolarity, inflammation of the ocular surface, and actual permanent damage as well. And all of these things contribute to this umbrella term of dry eye disease. If you look at your sort of Jews 2007 categorization, you can either look at aqueous deficient dry eye or evaporative dry eye. So the problem is either in not creating enough aqueous, or it's the fact that your tear films are evaporating too quickly. So we're looking at aqueous deficient, that's either Sjögren's or it's non-Sjögren's. And your Sjögren's is essentially, we'll talk about that in a moment. And then with your non-Sjögren's, that's either going to be a problem with your lacrimal gland, it's either obstructed, it's been traumatized, either with iatrogenic trauma or just, trauma to the globe, or the orbit. You've got a problem with the parasympathetic system, or you've got sort of drugs that the patient is taking that reduces your parasympathetic drive. And then you've got your evaporative problems. So that's either intrinsic to the eye itself. So you've got meibomian deficiencies, problems of your lid positioning, which again we've spoken about in the past, a low blink rate, and then extrinsic issues. So things like vitamin A deficiencies, wearing a contact lens, having a problem with your ocular surface. So all of these things can contribute. And what you'll find is a lot of the time the patient has crossover between lots of different factors. So a lot of them need to be addressed in managing the patient. So there's lots of different things that can contribute to your dryness, and this is the sort of formal categorization of the disease. When looking at Sjogren's specifically, you basically have a lymphocytic inflammation of the lacrimal and salivary glands. So these are patients who are going to present with a dry mouth and dry eyes, and it can really vary in the severity of the disease. And you're going to do some investigations as well as just investigations of your ocular surface, which we'll talk about in a moment. But specifically to Sjogren's, you're going to look at anti-SSA and anti-SSB. If those are negative, then having a rheumatoid factor positive and ANA positive as well can sometimes uh, indicate that the patient actually has Sjogren's. And you're going to treat these patients as you would any dry eye disease, but they may also benefit from things like parasympathomimetics, and potentially even some immunosuppression, because it's essentially an autoimmune condition, and something like rituximab can sometimes help with these patients in reducing their symptoms. So when it comes to examining your patients with ocular surface disease or dryness, you're going to be looking at the lids. You might find some blepharitis contributing to evaporative disease. You're going to look at the ocular surface. You might have some hyperemia on the conjunctiva. You might have these punctate epithelial erosions, as it's shown in that picture over there. Maybe some filaments with severe dryness. And you're also going to look at the tear production, and that's going to be with a tear break time. and Sherman's. And I wanted to discuss those specifically today because A, for your exams, it's helpful, and just generally clinically what you're actually doing with these examinations. So with the tear breakup time, you're applying a bit of 2% fluorescein onto the surface, get them to blink a few times to have it properly distributed over the surface of the eye, and then just ask them to stop blinking and then just watch them through the slit lamp. And you'll eventually start to see these dry patches start to appear. And those shouldn't really turn up within the first 5 to 10 seconds. Anything quicker than that, and you're a bit concerned that the patient has a dry eye issue. The other thing to also bear in mind is where specifically those dry eye spots are actually turning up. So if they are always exactly in the same spot on the cornea, we are actually looking at as potentially an epithelial basement membrane problem, or a problem with the cornea itself in that area, rather than just the problem with evaporative dry eye. So do actually look at where these spots are appearing. So watch the tear breakup time, watch it break up, and then get them to blink again, apply it again, and see what happens and see if things turn up in exactly the same spots. Shermer's test is looking at your tear production, and theoretically, it can compare both the basal versus the basal plus the reflex. But really, in practice, when you apply some anesthetic, you can't quite get rid of completely the reflex component, but that's theoretically what you're doing. So with anesthesia, you're basically getting rid of the reflex component in theory, and you're only assessing the basal secretion. So if within 5 minutes there's less than 6 millimeters of wetting of your Shermer's of your paper, then you're probably looking at reduced tear production. And then if you haven't put anesthesia, then you can imagine you'll get much more, and you're looking at both the basal and the reflex. And less than 10 millimeters here would be abnormal. So that's the difference between the anesthetized Shermers versus the non-anesthetized. Different ways of staining the surface. Fluorescein is what you're going to see most commonly. There are some places that might use rose Bengal, and there are specific uses for that, but they essentially stain slightly different things. So fluorescein stains conjunctiva and corneal epithelium. It doesn't stain dead tissue in the way that the rose Bengal does. And rose Bengal can be very, very painful, which is why you'll find it's not really used very commonly at all. Lysamine green does a very similar thing to rose Bengal, but it's less painful. But these stains are not really typically used in the clinical practice. Um, Anymore except in very sort of specialized cornea clinics, whereas usually you're just going to use some fluorescein. And another thing that you can do is fluorescein clearance, where you apply fluorescein to the surface and watch how it clears. But that's something that you can also be doing when looking at epiphoria and nasal lacrimal duct obstruction, as we've spoken about in the past. And lastly, that picture that you can see in the bottom right-hand corner is someone who's actually testing the tear osmolarity as well, as that can also contribute to dryness as well. Managing dry eye is quite multifaceted. There's lots of different levels to it, and you sort of approach it in a stepwise fashion and go up the ladder as necessary. So you start off with education. You're teaching the patient about what the disease means, the chronicity of the disease, the different ways that you can actually control things, maybe a systemic review just to make sure that there's nothing else contributing to the dryness. Start them on some simple tear substitutes and maybe some myelotherapy as well. And then you slowly start to work up. So you might start to think about some anti-inflammatory agents, maybe some punctal plugs, then going on to things like serum eye drops, scleral contact lenses that kind of come in with like a bath that can sit over the cornea, maybe permanent punctal occlusion, then sort of systemic anti-inflammatory agents and surgery. Now, these are all very sort of extreme approaches. So, for example, with surgery, you might even actually find some operations actually include gland transplants from the patient, so like submandibular into the lacrimal area to try and create some more tear production. But actually, what happens is in that you might actually get a bit too much mucus in the tear, so there are side effects. But these are all very sort of extreme scenarios. Really, the majority of your patients are going to sit very comfortably between level 1 and level 2, and some of them may venture into level 3. So with tear substitutes, you can either have the drops and the gels, your sodium hyaluronidates, some carbomer, your ointments, which includes things like vitamin A and like the paraffin ointments. These They last a bit longer on the eye and they're there to sort of act as a sort of lipid layer, but it's very difficult to mimic it entirely. And your sprays, which also act as a sort of lipid layer as well. These are all different ways of actually applying tear substitutes. And a lot of the time, it's just about finding the one that works for your patient. Um, I always tend to tell my patients that there's a bit of a mix and match. It's finding what works well for you. Obviously, there are things that are going to treat different parts of the tear film. But ultimately, it's finding the one that works for the patient. And the frequency will depend on the type of tears that you've given. The main thing to bear in mind whenever you're giving gels or drops is to find things that are not preserved and things that are preservative free, because those preservatives can actually be quite toxic to the ocular surface themselves and just exacerbate the problem. You can then think about reducing the outflow, and that's primarily essentially with punctal occlusion, and that can either be temporary with things like a collagen plug. Those tend to last a few weeks, they'll fall back out, and they're a good trial period for patients to see whether or not those punctal plugs work. You can then think about things that are a bit more permanent but reversible, so silicone plugs. Problem is with squeezing of the eye and the blink, these can sometimes just fall out, and the only way to really permanently close your punctum is actually with cautery. You do want to be really careful about approaching permanent punctal occlusion because you actually find that patients' epiphoria is actually much more annoying than dry eye for these patients. They'll actually be much more upset if they come in with a very watery eye because you've essentially permanently closed their punctum. So having that temporary closure can really be a good trial period for these patients to see whether or not punctal occlusion would work quite well. Primary temporary occlusion and permanent occlusion can be both to the upper and the lower, but if you think about it, the lower is doing most of the work. So, targeting that is sometimes the best bet in trying to create a wetter surface to the eye. Anti-inflammatory agents, these can either be steroids. You're mainly going to use something like a fluoromethalone because it reduces the risk of things like having a pressure rise or cataracts because it just acts really at the surface. But you want to be using these sparingly because you don't want patients on long-term steroids for multiple reasons. You can think about oral tetracycline, something like a doxycycline in adults. You're not going to want to use this in kids. You might want to use something like azithromycin instead. But a 3-month course tends to be what's offered, 100 milligrams a day, and you're using the anti-inflammatory element of the antibiotic here for the lid disease especially. And then finally cyclosporin. And you're essentially looking at something like a Nykervis or a Vacasia in children, and you can start them on once a day. You can go up all the way up to 4 times a day. And these are incredibly safe drops. There are very few side effects with them. The only thing to bear in mind when you're telling the patients about them is that they can take some time to work. So, they're also used in things like allergic eye disease, but essentially can take up to 6 weeks for their anti-inflammatory function to work on the surface of the eye. So in the interim, you might want to use some steroids to help reduce the inflammation more acutely. But the cyclosporin wasn't, the steroids are basically there to bridge them over while the cyclosporin gets to work. So just tell them they essentially need to persist with it. It may not work overnight, but in order to start to see the benefits of the cyclosporin, it's regular usage over time and then up to 4 to 6 weeks for them to start seeing the benefits of that drop. Um, so essentially, to summarize, it was a quick session today, just looking at things like dry eye disease, and it's a multifaceted disease. Lots of different things can contribute, and in the majority of your patients, there will be multiple components to the disease, and all of those things need to be targeted. And then targeting the wrong problem can really frustrate the patient and you. So really taking some time to figure out what the issue is, educating the patient on the disease can be really helpful. So for example, when we're talking about things like education of the patient, we're thinking about things like, adjusting the room temperature. We're talking about things like, thinking about the air conditioning, room humidity, and there's lots of different things that the patient can think about and change in their lifestyle that can make a difference before you've even medicalized them. So, take some time, figure out what exactly the problem is, and educate the patient on it. Thank you very much for joining. Please do remember to fill out the feedback. And as ever, we will see you at the next one.